you, IRHA, for hosting this session. It's a pleasure to be with you on this beautiful day. I was just able to open my office window and let some fresh air in. Hard to believe a week ago we were shoveling snow still, but beautiful day. And hopefully the Purdue logo. If you're a Purdue fan, we have good luck tonight at 7:10 as we take on Texas out in California for the round Sweet 16. Um, both Indiana schools beat Miami, one in football, one in basketball. So hopefully Indiana can come together and root on the Boilermakers for the NCAA. But it's a pleasure to be with you today. Share more about mental and behavioral health. As Ali mentioned, that this session is graciously funded and supported by the Indiana Department of Health State Office of Rural Health Flex Initiative. We are doing 4 webinars during this funding period, which runs through the end of August of 2026. This is our first of 4. We're actually doing a 3-part mini series looking at behavioral health. We did a survey of our critical access hospitals last year. Our next survey is going to launch here in the next couple of weeks. And the number one area of support and need and concern was behavioral health. So we're doing a 3-part series. This is a primer. This is an introduction for a lot of you. This may be some review information, but I think it's important that we always level set and we're always on the same page moving forward. And then next week on April 1st, not a fool's or a joke, but on April 1st, we're going to do a whole session looking at interfacility transfers specific to the behavioral health population and behavioral health conditions. And then on May 6th, we're going to do the 3rd part of our mini series on behavioral health around the idea of telehealth and the support of telehealth. So you're going to be hearing throughout my presentation today, I'm going to be mentioning, hey, in this upcoming presentation, we're going to be having some of this information. I do want to give a shout out to the team that surrounds our Purdue team. Susan Grasham, who is our program manager, and then Sue Hancock, who's our doctoral student, working closely with us on this presentation. Sue is in class today, but our next 2 sessions are on Wednesday when we don't have class, or she doesn't have class, and she'll be joining us for some of the presentation as well. As Ali mentioned, I have the chat and the Q&A on the screen that I'm looking at with my camera. My slides are on my other screen. So please, as questions arise, please put those into either of those avenues, and I'll be able to address those as we go on. So as I said, today is a primer, mental and behavioral health in rural communities. Where are we at as a nation? Where are we as a state? What are some of the ways that we frame our thinking around this? And then as we do this deeper dive in our next 2 sessions on interfacility transfers and telehealth, what does those look like? So let's go ahead and start, at some of these national trends in rural mental health and some of those national things that we're seeing. So we first look at nationally, where is rural mental health? What are the demographic, or sorry, the epidemiological data that we see? We are now far enough out from COVID. It's kind of hard to think that 6 years ago we were bending the curve for 2 weeks and kind of having that discussion of what that looked like. And then April was the total shutdown month, and then May was the start of reopening and rejoining as we started to join those things. But we're now so far out past COVID that our data is starting to normalize, and we're starting to see what we were seeing prior to the pandemic, or we're seeing changes from what we were seeing prior to the pandemic as we're adjusting to the new normal and the increase of social connection and technology and things like that. But if we look at our data of for non-metro rural individuals 18 older, so not the pediatric population, we have 3 main data from our national survey on drug use and health. Report having a mental illness. This is self-report, self-identification, self-reporting of having serious thoughts of suicide in the past year, and then misuse of opioids in the past year. And the key here is the misuse. So if you're taking them as prescribed post-surgery or post-procedure or to treat chronic pain, you would not identify in this, but that misuse. And we saw in 2024, 7.2 million individuals identified of having a mental illness. 1.7 million had a serious thought of suicide, and 1.2 million misuse opioids. If we look at the trends from 2023 to 2024, we see that there's been an increase in all 3 of these questions from 2023 to 2024. 2025 data will probably come out in July or August, so we're still pretty early in that data being analyzed and being released by the government. Some of that data was also delayed due to the shutdown that occurred back in the fall of 2025, from October through the middle part of November. But if we look at report of having mental illness, 22.9% of people who live in a non-metropolitan area identifying of having a mental illness. 5.5% have a suicidal thought. So 1 in 20 individuals identified having a suicidal thought within that year. That's a 0.7% increase year over year, which doesn't sound like a lot, but when you're looking at the treatment and the support needed, that is significant. And then a 0.3% increase to 3.7% for misuse of opioids. If we look at then how do we stratify some of these data, looking at both small metropolitan, large metropolitan. So if we bring in that urban area, again, probably preaching to the choir here, but non-metro is the highest in every category that we measure. So we use RX opioids non-medically, so 3.7 compared to 2.7, 2.6 for our small and large metropolitan. Cigarette use, which isn't necessarily tied directly to mental health, but is usually a co-occurrence with some of the more serious mental illnesses or SMIs that we measure, 22.5 versus 17.3 and 14.5. Smokeless tobacco, 6% versus 3.6 and 2.4. And then methamphetamines, 1.7. So compared to 0.07 in small metro and zero point 0.7. So in contrast, rural adults use marijuana, illicit drugs, cocaine, hallucinogen inhalants at a lower rate, pardon me, than small. So really, we're looking at methamphetamine, we're looking at tobacco, but that marijuana, illicit drugs, cocaine, hallucinogen inhalants at a lower rate. And again, this gets into what is the treatment protocols that we have. Um, I always say in my classes, and when I'm working with people who are new to working in rural communities, even if they come from rural communities, that not all rural communities are the same. So our solutions need to be unique, and we're going to talk about those towards the end as well. If we look at alcohol utilization, binge drinking, we see that alcohol rates are the highest, especially in ages that are not eligible by law to be utilizing those products. So use of alcohol in 12 to 20-year-olds, 31% roughly in rural compared to 28.4 and 25.3. Binge drinking in the past month for our pediatric 12 to 20 population. I know 18 to 20-year-olds are not pediatric, but below that legal age of purchasing of alcohol, 11.2%, and then tobacco products at that 12.7. Again, we see that higher rate in rural, non-metropolitan communities. We look at suicide. Suicide obviously is a significant issue for all, and something that as a country we definitely need to address. And we are seeing trends on those different things, especially on a college campus. We are an epicenter for suicides and something that we definitely have communications on, especially as we're reaching the end of our semester and the final season. But if we look at rural and non-metro at 19.74 compared to small metro and large metro at 16.7 and 12.77. Suicide rates are higher, more prevalent in a male population, but females are still higher. And then we look at ages and where is that age the most prevalent? Again, rural is leading, non-metro and rural is leading in every age category, but we normally see that intervention at that 36 to 64 population. So again, as we start to think about solutions, or interventions that we need to design to support populations, that 36 to 64, we're potentially looking at the Medicaid population or the working private insured population. We're not looking at a pediatric population. We're not looking at a Medicare population. I'm very careful when I say this, but the 65 and older, that Medicare older population, we do see a decline there. So again, things that we need to look at as we approach these different topics moving forward. So what are the state, what are the county trends? So that's the national. Where does Indiana reside on these things? And I think we can see. So what is rural? So non-metro, there's over 68 different definitions of rural in the federal government alone. This does not include state government, local government, and or research institutions that like to make their own definition. But we are using this non-metropolitan population definition. So these are the counties in the dark blue or the black color, depending on the zoom is bringing this over, where we see that non-metro. Indiana has an estimated population of 6.8 million, of which 21.8% or 1.5 million individuals live in those non-metro county areas as well. So where do we look at? So we look at Indiana, United States, then Indiana as an overall. It is hard as we get further out and or further into subpopulations really to say Indiana rural specifically. But we recognize that Indiana is not the healthiest state out there. We tend to be past the mean and the median towards the unhealthy side. So we look at questions of poor physical health days, so average number of physically unhealthy days in the past 30, National average is 3.9, Indiana is 4.2, and we have a range of 3.1 to 5.2. Urban tends to be below the average, rural tends to be above the average, but there are always uniquenesses out there. It's not a guarantee. If we look at poor mental health days, so if we think of behavioral health, so again, self-identification, reflecting back in the past 30 days, how many days did I have a poor mental health day? National average is 5.1. Indiana, that average is 5.5. And again, we see that spread around that mean of 5.5 of 4.8 to 6.6. We look at frequent mental distress, so percentage of adults reporting greater than 14%, 18% of adults were identifying that they had 14 or more poor mental health days in a 30-day period, so over half or more. Suicide was higher, life expectancy in Indiana is lower, and then premature deaths. So this is years of potential life loss before the age of 75. Age adjusted, it was at 9,500 compared to the national average of 8,100. This idea of premature deaths is very important because this is an area in premature deaths. Yes, we have physical health conditions that may identify that, but behavioral health is a leading indicator into this metric as well, especially when we think of suicide, which is that terminal end of a life as a premature life. We saw in previous slides, suicide tended to occur in our younger population below 65. Remember, premature death is counted as a 75 or younger or 74 or younger death. We see that Indiana is above the United States, and if we look further out, and I'll use my mouse if that helps, if we look further out, especially post the pandemic, our differential away from the national mean is getting greater, which means that we have more work to do, or other states have identified solutions to support some of these things as well. And we can tease out the data later looking at it, the causes. If we look at the county level, so again, we want to look at county. So where is that highest um, uh, potential healthy life? So darker here tends to be an overall metric of higher health. And if we look at our suburban area around the Indianapolis area, that is where our darkest colors are. As we further out away from the Star of Indianapolis, the Crossroads of America, Circle Center, we start to see those lighter colors where poorer health tends to be. And then we get into those yellowish colors where our least healthy is. And if we overlaid a few slices back our rural non-metro counties onto this map, you're going to see there's a high correlation of that moving forward. We also have to recognize that infrastructure is a driver of our health. As you look at the different areas and aspects of infrastructure, we recognize that connection into the healthcare system is a potential solution. When I say healthcare system, that is broadly defined. That's not always going in and seeing a physician every so often. Maybe that's seeing a nurse practitioner, physician assistant. Maybe that's a licensed clinical social worker. Maybe that's a community health worker with lived experience similar to the situation you're going in. But again, if we look at what are our ratios, so again, in Indiana, we tend to be behind the national average, and our spread tends to be significantly behind the national average. So if we look at primary care physician, national averages, there's 1,310 individuals to every one primary care nationally. Indiana, that gets more broad at 15 to 10, and Indiana, our furthest out, is 29,000 to 1, almost a factor of 20 greater than what we see in Indiana. Mental health provider, again, this number is less because it's more broad. We're not just talking about clinicians, physicians who can prescribe, but provider LCSWs, master's trained, maybe even baccalaureate trained, depending on the area. National average is 290 to 1. State average is 440 to 1, so almost 1.5 times that national average. And then our range is all the way up to 14,130, which again, we're now looking at a factor of about 50 times greater there. In an uninsurance rate, Indiana is leading here because we have expanded Medicaid. We'll talk about that in a couple slides. Preventable hospitalizations, air pollutions, broadband access. Indiana Rural Health Association with the IT and network has done a lot of work around broadband access. And as we get into solutions around telehealth, there is the discussion about broadband and what is the ability of that. But the beauty of behavioral health is you're not sharing a lot of complex imagery like you would with X-ray or ultrasound or CT or MRI. And there are the ability to use common devices, cell phones, and things like that to be able to support those things. And cellular signals are making a big factor out there. Primary care physicians, so Indiana, like we are at a steady state. We're above the national average, and we pretty much have been above the national average for the last 11 years. If we look at national access to providers, again, I talked about there's a lot of different types of providers. So we look at this is per 100,000. So counselors in urban is about 140. At the state, at rural is 80. This is national data. Nurse practitioners, so prescribers or psychiatrists, a huge linkage or decrease there. So medication or pharmacological treatment or is a potential necessary intervention outside of psychotherapy or talk therapy, and they need that co-occurrence, so that co-brain support for that patient. We just don't have a lot of those providers as a nation. Rural especially does not. Psychologists and social workers. So again, that talk therapy there as well. National data, we look at what is a mental health professional shortage area or a HIPSA, HPSA. We love our acronyms in healthcare. Here, so non-metro and micropolitan are the green shades. The metro areas are the blue shades. The darker the color, the higher need you have, regardless if it's a darker blue or a darker green. The lighter the color, the better you are. But if you're gray, you're simply not able to calculate it because we simply don't have enough data. So this is the national average, but if we zoom into Indiana, again, we can notice that there are areas that are very dark colors, both in blue and in green. So there is significant need to support those activities moving forward as well. If we look at uninsurance rate, so we see a great decline or a negative slope if you're in my biostats class, but we see a great decline of uninsured in about 2014 to 2016, and this is during the implementation of the Affordable Care Act, also known as Obamacare. We saw the increase of exchanges for those who did not qualify for Medicaid. We also saw expansion of those who qualified for Medicaid, and be able to support individuals there. Indiana was one of the states. We were one of the early states under Governor Pence to expand Medicaid into HIP 2.0. And we saw a great decline there and actually are below the national average, positive, for the uninsured population. So people have the means to potentially cover or pay for the support that they need. But I think this is something that we really need to look at and monitor. Indiana is a leader in our HIP expansion, HIP 2.0. But are going to be a lot of changes through the One Big Beautiful Bill or HR 1 and other state level policies at the Medicaid level and also at the exchange level. As subsidies, the enhanced subsidies post the pandemic have expired and were not renewed at the end of 2025, going into 2026, that we may see a higher uptick of uninsured. This is going to, again, limit the ability that people may have in order to receive treatment and support. If we look at preventable hospitalizations, we have seen marked improvement. We are still above the national average, but we have been able to see declines proportional to what we would see with the national average, and things moving forward there. So one of the models that are coming out when we look at what are the barriers to mental health care and kind of how are we framing our next two, which are much more going to be solution driven. Again, this is the primer, are what we call the four A's of behavioral health: the accessibility, the availability, the affordability, and acceptability of those things. We're going to do a longer discussion of those. So while prevalence mental health is similar between rural and urban, service availability can be very different. So we first have to say, what is the accessibility of that provider? What's the travel distance and what's the associated cost? What is the availability of that? Do we have trained providers? Do we have all the appropriate services? What is the affordability? Am I uninsured or am I underinsured? Just if I have insurance doesn't necessarily mean that I have an insurance where I can meet my copay and my deductible. And as we're wrapping up Q1 of the year, several people may be foregoing treatment until they're able to meet that copay or deductible. And then lastly, what's acceptability? What's the stigma and the confidentiality concerns associated with that? So first with accessibility, we have to talk about what are the travel issues. Is it difficult? Are roads accessible? We had a very harsh winter, especially in January. Actually, our February was very mild, but our January is a very harsh winter. Southern Indiana, you got more snow than we did up here in the north, but we all got considerable snow. Gas prices are soaring right now, about $1 higher as on a national average in the last 30 days. So what is the cost associated? Do I have the ability, both personally with my vehicle and the fuel in my car or vehicle to get there, but then also the availability of roads and the safety of those roads? Do I have to depend on others to transport? Maybe I don't have the ability to get to my appointment. Do I have a support network, natural supports to help me with there? And then what is the availability of public transportation? And transportation, I know, is a huge issue. They also, accessibility of patients not insured for mental health services, it may be too costly to pay for the full charge, so therefore they're not able to receive all the treatment they needed. And patients may lack adequate training to recognize mental illness. So providers who are seeing it may not be able to get down because they are seeing so many patients across so many different domains of health need that they're not able to recognize that mental concern and refer out for those things. Accessibility is one of those things, and I think it's something that we really next week on April 1st, when we talk about interfacility transfers, is what is the models there and what are some solutions to support building that network out there. Accessibility also with telehealth. There are definitely times, 100%, where a patient and provider need to be in the same physical location, and there needs to be that hands-on, touch-based delivery of care. But there are also other times where, again, I can sit in a private room with a device and do a teleconference or a video conference with someone and have that support as well. Next, we need to ask, what are the availability of providers? Our clinics are less likely to offer mental health services given low reimbursement rates and other administrative issues. High no-show rates amongst the mental health patient population also drives to barriers. I build a model where I have a counselor and I expect the counselor to service so many patients in a day. And if there are a lot of no-shows where I can't bill for that service, then it gets very difficult for me to continue offering that service as a provider. Mental health professionals are more likely to practice in urban areas, causing chronic shortages. We can have a longer discussion in the Q&A about that. And then federal cuts in health insurance programs are resulting in fewer people insured as we're seeing changes in both our Medicaid, our exchanges, but then also employers. We're seeing at Purdue, our premiums are going up, our deductibles haven't changed yet, but definitely a tool that could be out there as well. So again, what's the potential of the solution for telehealth to be able to support some of these things? Affordability. All these things are interconnected. Medicaid cutbacks, the elimination of the premiums, but also the rising cost of goods across the spectrums. Things are just getting more expensive as we see continuous growth in our economy. As GDP, things are getting more expensive. So how do we balance those things? And then lastly, the acceptability of services. So there is a stigma to mental health. I always give the example to my students of just think if I walked in and said, hey, first day of class, I have a condition and there's times where I'm going to step out of the room to sip on a beverage to get my sugar levels up, or I may need to take a quick snack because, I have diabetes. Not much is going to be thought about that, but if we're honest, and like for me as well, like if I got up and said, hey, there may be these things I need to do due to my mental health, right? There's a stigma associated with those things in today's society, or kind of a fear of what others may think about those things. Especially in a smaller community where people know vehicles. I mean, I know when I drive into the office, I know people's cars. I'm like, okay, so and so's here, so and so's here. Haven't seen so and so. I wonder if they made it into the office today. But if I'm in a small community and my vehicle is outside of a provider's office, especially their mental health only provider, there could be a stigma there. Skeptical about confidentiality due to fewer providers. I can't drive across town. We're all going to be in the same community, so there's that concern. Reliance on informal care, so family, friends, or religious leaders provide that support. And then if they are using telehealth, do they have a private spot in their home or at their office or someplace to be able to do that call? Again, telehealth is a solution for those different areas as well. So what can communities do? Again, our next two sessions are going to be a lot driven on solutions, deeper dives. These are areas that were identified through our survey of areas that there's a need for additional technical assistance and learning about those. But we don't want to leave this webinar with just all this heavy topic. But what can we do? So one is expanding telehealth services. Again, that's coming up. Another is looking at loan repayment programs and state tax waivers to behavioral health graduates. If we look at coming from an academic institution, students are constantly asking, what can I do for this job? And if I am going in debt, which sometimes that's necessary, what is the payoff plan to support that? Am I going to have a high enough income where I can quickly pay off that debt? Or are there providers, are there employers, a part of me, that will hire me, that there's some sort of share? Hey, they're going to make payments on my debt as long as I work there, or they're going to wipe away my debt as long as I serve so many years. So looking at those different aspects. Also for providers, it's recognizing that clinical rotations in rural settings for behavioral health professionals in training. If they see rural, if students, if practitioners who are learning and learners are in rural communities, they're more likely, data supports this, more likely to want to go back and serve in rural. So how do we support those aspects moving forward? Utilizing the school-based health center model for mental health screenings and services for youth. How do we not add? Education has a lot. Our school teachers, especially our K through 12, especially our K through 5 educators, are doing more each and every day beyond just that educational component of ensuring the social drivers of health are being met and the well-being of their student population. But how can we utilize that area to really be able to identify and support those things, and identify where's the greatest need and where could the counselor come in? IRHA had a previous funding, the Indian Rural School Health Network or ERSKIN, really of identifying how do we put telehealth equipment into the school where there's someone trained to help the student utilize that. The broadband connection is pretty stable because the school has robust internet, and there's a private site that they can go and do those. Again, how do we support those things? And primary care, pardon me. Thank you. In primary care, primary care providers are often the first to seek evidence of mental health and behavioral problems. So, how do we co-locate or integrate behavioral health care, primary care into those settings? So when I see that truck outside the clinic, I don't know if they're there for blood work, if they're there for a physical, or maybe they're there for a mental health appointment. It helps to reduce that stigma. It also allows primary care providers to have trusted support around them. So as they're seeing their patient flow, they're able to do those things. We're going to talk a lot more about this in our telehealth session about some of the different mechanisms out there in the Medicare program to support these things. But there's a lot of innovative things happening there. We'd be remiss if we didn't talk about the Rural Health Transformation Funds, or RHTF or RHTP, the Rural Health Transformation Program. At the state, our region, Region 3, we have our call at 1 o'clock, our weekly call, to talk about our regional meeting, which is 60% of the funds, but 40% of the funds are also at the state level for state initiatives. And there are funds. One of the 11 initiatives is growing that rural health, behavioral health workforce. There's $1 million right now in this first year dedicated to how do we build that workforce. But as each of you are working in your own regions, again, I've been participating in Region 3 because that's where I'm born and raised and live. But what are some of the solutions and grow that you can utilize to really bring in that behavioral health workforce if that's a need that's been identified amongst your region? Um, if it's not, then continue the work you are doing. But if it is, next week when we talk about interfacility transfers, are the things that funding could seed to help you build so it's sustainable in the long term? Or there's seed funding that you can use for telehealth to help build towards that, or a way to get providers to come into the community? Again, all those things to keep in mind. So we have that 1.06 million in year one for behavioral health workforce. There's also the region specifics and grows with those proposals to do. And then there's additional funds being requested. Also, at the very end, I'm going to share our email, but if you're driving or listening in hopefully you're on an outside walk and it's wonderful. The email to get to me and my team is really easy. It's rural, RURAL, at purdue.edu. That goes to our team and we're checking those things. But there are a lot of toolkits out there. It's also important, I think, as our team was looking through these toolkits and curating and wanting to support some of these things, we also have to look at behavioral health in so many different facets. The pediatric population is going to be different than the adult population. The adult population is going to be very different necessarily than the geriatric population or the elderly population. Behavioral health, for a while, I was very active when I saw RHA, and Allie was a direct colleague and not a distant colleague. But in the opioid crisis and substance misuse crisis that we have, but the solutions for that are different. And sometimes, I know I was guilty of this, we're so focused on that sometimes you're missing the depressive or the anxious population that didn't have a substance misuse co-occurrence occurring with those. And we need to make sure, and that's a different types of solutions. And these toolkits really get into some of those. Again, happy to share our slides, happy to share those toolkits with you as well. But really be defining what is the population you're working with and recognizing that a one-size-fits-all solution is not always the best. And there are some uniquenesses to these different populations to support because The suicide rates are increasing. Our opioid misuse or our substance misuse rates have increased. We're starting to see a decline, but they've ballooned greatly above what they were prior to the pandemic and are still above that threshold. Another area is mental health first aid. So again, I'll link out here to some work that NRHA is doing, a National Rural Health Association is doing that we want to connect you with. But this is an 8-hour training. I know I'm CPR trained. I'm first aid, physical health first aid trained. But I was able to personally do the mental health first aid that Purdue was offering, and it was interesting and fascinating to hear the concepts and the different ways that I, as a layperson, I'm not a counselor, I'm not a psychiatrist, but the simple changes I could make in my everyday interactions with people, but also with my students, with my coworkers, with those that I supervise, that help with the mental health moving forward as well. So this is an 8-hour training. It's all around the state. A lot of different providers are offering that. I encourage you, again, to be able to do that and take that if that's an opportunity for you as a solution. So with that, we wanted to leave time here, our references, if you want to get back to the raw data and do a deeper dive into your individual county or the regions that you serve. But here's our thank you. My email is on here. It's cjmullen@purdue.edu, or that rural@purdue.edu also goes to our team. It is checked. I know sometimes we see those random like emails that don't have a name. You like, do people? Yes, we do check those. Susan on our team, as well as others on our team, check that email frequently, and we will get back to you, share our slides, share the recording with this. We're happy to have an individual discussion of, hey, what can we do to help? So with that, open it up to questions, Q&A as well. But do encourage you, please come back April 1st and May 6th as we get further into these unique areas as well. So with that, are there questions or things that we talked about or discussion that you want to have? We got about 20 minutes left, but please do that. Otherwise, I will let you get back to your mental health and do a walk outside away from devices. So I see Allie has opened up our post survey as well, and that data is very helpful for us as well.